So we are done with 2015 booklet, and now we are starting with 2016 booklet, and this is the first tutorial. So let's begin. You are a doctor on duty. A patient after a successful resuscitation that's drawn in was delivered to an admission room. So after successful resuscitation, put it at the back of your mind. Now the BP is 90/60, heart rate 120, respiration 26. Patient is unconscious. Pupils are moderately dilated. Clonic tonic convulsions are observed. Make the diagnosis. Make the diagnosis. So actually what we're having here, we are having what we call post-resuscitation disease. Why? Because all of these conditions are occurring after resuscitation. Now, what then is a post-resuscitation disease for which we are saying this is it? This is simply an abnormal physiological state. Abnormal physiological state which occurs when the whole body ischemia is followed by a whole body reperfusion. Now, the reason why you are giving, you're trying to do resuscitation and stuff like that is because the person is having inadequate perfusion, isn't it? Inadequate perfusion. So either air is not entering, so we have to, put in air, or either there's too much fluid, so exchange of gases is not happening. That means there's inadequate perfusion occurring. So sometimes the body gets overwhelmed with how the resuscitation takes place. The body gets overwhelmed. And so therefore it begins to produce what we call vasodilatory shock. Vasodilatory shock. And that's actually what is one way or the other is happening here. The person this is not yet shock, but it is entering, it is going. And this is also causing the unconsciousness and then, things like that. So over here, that is what we're going in with a post-resuscitation disease. Post-resuscitation disease. Because the body is getting so overwhelmed. So overwhelmed. So your answer here is A. Some of you love this question so much because you have seen it a lot. A 32-year-old welder complains of weakness and fever. Before that, what disease can somebody with welder have? What disease? Anyone? It's a revision. What disease? Yes.
Electric ophthalmia.
Ophthalmia is there. Then someone also mentioned siderosis. Yes.
Metaconiosis.
Exactly. Thank you. So at least you have so many things in your head already, which is quite good. But now let's look at the question. His illness initially presented as tonsillitis 1 month ago. Tonsillitis 1 month ago. On examination, I think temperature is 38.9, respiratory rate 24, heart rate 100, BP is this, hemorrhages on the legs, enlargement of the lymph nodes, CBC count 70, hemoglobin is 70, which is quite low. RBC is 2.2, WBC is 3, with 32% of blast. 32% of blast. And now you can see a lot of diseases happening. But for the fact that this blast is 32%, should give you an indication that we are looking at a case of what? Of leukemia. We are looking at a case of what? Leukemia. Leukemia, as simple as A, B, C, D. So the question now is that what is the cause of the anemia? What is the cause of the anemia? So over here, you are looking at what? Acute leukemia. Acute leukemia. Acute leukemia. All right. And again, I believe when I ask you of questions or disease related to tonsillitis, you already have it at the back of your mind, which is very good. Again, this question, we have solved it before, so let's not waste my time on it. A regional cardiologist is tasked with the development of a plan for medioprophylactic measures aimed at a decrease of cardiovascular mortality. Cardiovascular mortality. What measures should be planned for secondary prevention? Guys, who can tell me what is the aim of primary prevention? Who? Anyone?
Prevention of recurrence and complications.
Come again.
I said it's prevention of recurrence and complications.
We are talking about primary.
Vaccination is the prevention of the occurrence of the disease.
Good. Great. So let's mute microphones. So basically, we are saying that in primary prevention, you are preventing the disease from even coming. That is primary.
Somebody's mic is on.
Someone's mic is on. Dr. Pam, yes, good. So in primary prevention, we are saying that we are preventing the disease from even coming. With secondary, we are trying, the disease has come, but we are trying to reduce reoccurrence and complication. In secondary, complication has come, isn't it? But we are trying to what? To prevent permanent disabilities. So you see how interesting this whole thing. So if you understand it that way, this question will be easy for you. So what measures should be planned for secondary prevention? And of course, your answer is what? Prevention of the reoccurrences and complications.
Please, is it possible you can take the primary, secondary again, please?
So when we say primary, we said in primary prevention, we are preventing disease from happening in the first place. So that's what we give us. Example is vaccination. So in vaccination, it doesn't mean that disease has come. It means the disease can come, but we are preventing it from coming. Personal hygiene is a way of primary preventive measure because you are trying to prevent infection from happening. So that is what primary prevention. In secondary prevention, the disease has come, which means that you are sick. Like I am now, like I was before, where I had typhoid fever. It means now I am sick. Now I can't say I'm doing primary prevention. Now I'm going to do what? Secondary prevention. What it means is that I'm going to prevent complication from happening. And you know, one of the complications of typhoid fever is to have perforation or peritonitis. All of these can happen. Now I'm trying to prevent it from happening. I'm trying to prevent the reoccurrence again. And you can remember that I told you some time ago, I think 3 weeks or 4 weeks ago, that I had, typhoid. And because I didn't take the full course, I thought I was okay, and it came again. So that means that my secondary prevention was not duly done. So it came again. That's a reoccurrence. And then complications from happening. Good. Then we have the tertiary. Now in tertiary, complication has come. But now we are trying to prevent permanent disabilities from happening in a way that you now cannot go to work again. You can't do anything again. That is what tertiary. And that's why we have the rehabilitation centers for that. I hope we are okay now. So the answer here is B.
Thank you.
Welcome. An 8-year-old boy developed a temperature of 37.5 2 days after his recovery from the case of upper respiratory tract infection. Respiratory tract infection. He complains of suffocation, heart pain. Objectively, the skin is pale, tachycardia, the heart sound is weakened, short systolic murmur in the fourth intercostal area near the left edge of the breastbone. What heart disorder such clinical presentation is characteristic of? Now, good. So now we know, many of you know that if you are having upper respiratory tract infection, and we know that one of the causes of upper respiratory tract infection that can have a problem with the heart could be tonsillitis. Many of you are thinking of it in that same manner, isn't it? Which you are not far from right. Okay, so tonsillitis could be what? The causative agent for this thing happening. And that means that we can have what we call a rheumatic fever, rheumatic heart fever. But this is not a rheumatic heart fever, but rather a non-rheumatic heart fever. And this is the reason. There's one key thing that you need to know. that will help you to differentiate between rheumatic from non-rheumatic, and that is the duration after recovery. I repeat, the duration after recovery. Duration after recovery. Now we realize that in the cases of tonsillitis or upper respiratory tract infection that has lasted for maybe 2-3 weeks, then they will tell you 2-3 weeks after treatment of tonsillitis, 2-3 weeks after inadequate or after being infected with tonsillitis, this happened, that happened, that happened. That is rheumatic. But with a history of just 2 days, it's not enough for us to classify it as a rheumatic. And so therefore, over here, we will consider non-rheumatic myocarditis as our diagnosis. So your answer here is what? Is E. Is E. So always look at the duration. A woman complains of muscle weakness and a general fatigue, dyspnea, vertigo, brittleness of hair, nails, urge to eat chalk. Even this chalk alone to tell you, this one to tell you that you are dealing with what? Iron deficiency anemia. Iron deficiency anemia. And look at it. There's anisocytosis, poikilocytosis, serum iron is 10. What diagnosis is most likely? Definitely, you are thinking of a case of what? Iron deficiency anemia. No two ways about it. Hair loss, brittleness are classic for iron deficiency. And of course, hemoglobin and color index also confirms it. This is low, hemoglobin is low. All right. So your answer is E.
Dr. Ba.
Yes.
Dr. Ba.
Yes.
Usually, sorry, let me add one more thing to what you're saying.
Sure.
So another point for that is ability to eat chalk. Like,
yes.
want to eat chalk. That is the main point for
iron deficiency.
this particular iron deficiency.
Yes. And usually, those who are pregnant, they like it a lot. Pregnant women like it a lot.
Pregnant, yeah.
Yeah. In Ghana, we call it
It's a condition called pica chloretica.
Come again?
It's a condition called pica chloretica. It's when the individual
great
natural stuff.
Great. Text it into the how do you call it?
The group.
The group so that we know the word. All right.
My brother, you will type that one on the group.
Yeah, you will type it. A 24-year-old patient visited a doctor complaining of enlargement of his submaxillary lymph node. Dami, your hands are up. Is it urgent?
I can say it after. I just wanted to address something. I'll address it after.
Okay, good. All right. Objectively, submaxillary, axillary, and inguinal lymph nodes are enlarged. Chest X-ray shows enlarged lymph nodes of the mediastinum. Blood test is 3.4 erythrocyte. That's erythrocyte. Hemoglobin is this. Color index is 0.88 platelets, 190 leukocytes, 7.5 eosinophils. That bound neutrophils is this. Segmented 67% lymphocyte. That. The question is, verify the cause of lymphadenopathy. Verify what must be prescribed to verify the cause of lymphadenopathy. Lymphadenopathy. And lymphadenopathy or adenopathy is simply a disease of the lymph nodes in which there are abnormally in size. I mean, the cells are abnormal in size, or they are not what? Consistent, or they are inconsistent. Okay. And usually we are thinking of, or it's more of inflammatory disease, I mean, pathology. So you can be thinking of things that have to do with what? Lymphadenitis, and so on and so forth. And usually to verify, you have to do what? An open what? Biopsy of the lymph node. As simple as that. This one, no stress. Your answer is just A. We already know it. We've discussed it before, so no stress. Then some two are not on the Telegram page, so add it to the Zoom so that they can write it.
Thank you.
A 32-year-old patient, welcome. A 32-year-old patient complains of cardiac irregularities, dizziness, dyspnea at physical exertion. He has never suffered from such condition before, so it has never happened before. Objectively, pulse is 74, BP 130, auscultation revealed a systolic murmur above the aorta. The first heart sound was normal. ECG showed, guys, look, ECG is showing what? Hypertrophy of the ventricle. So this is where your answer is hypertrophy. Signs of repolarization. But now I know you know what controls repolarization. Echocardiogram revealed interventricular septum. Revealed that the interventricular septum was 2 centimeters, which means that it's also quite heavy or large. What is the most probable diagnosis? Like I said, your answer was rightly mentioned over here. So you're looking at what? Hypertrophy of the heart. So basically, the right answer here should be what? Hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, whereby the heart becomes what? Thickened. Becomes what? Thickened, very thick. So your answer is A. 35-year-old patient's wound with a suppurative focus was surgically cleaned. Now, talk about suppurative, it means pus formation. It means purulent, or it can mean purulent. Now, on the 8th day after the surgery, the wound cleared from its necrotic content and granulations appeared. However, against the background of antibacterial therapy, the body temperature keeps at what? It's high, 38.5 to 39.5. There are chills, excessive sweating, euphoria, heart rates, complications of local pyoinflammatory process can be seen. Or what complication of this has happened? So, of course, with the history of the fact that the person had a suppurative focus and they surgically clean it, and 8 days later, it came again. 8 days later, it came again. And this time around, it's keeping with high temperature and things like that. Chills, all those things mean that there are signs of what? Severe infection. And when we talk about severe infection, what comes to mind is what? A sepsis development. Sepsis development. So here, A is the complication that has happened in this patient. A 60-year-old woman has been suffering from arterial hypertension for 15 years. Arterial hypertension for 15 years. Again, you begin to start thinking about a complication that can involve what? Hypertension. And we've discussed this before. Many of you contribute to this question, but let me just go over it for the sake of learning. Now, after recurrent stroke, she had started complaining of unmotivated bad mood, problems with attention, concentration. She forgets to close the entrance door, cannot recall event of the past. Computer CT, computer tomography shows area of post-infarction necrosis. Post-infarction changes in the cortical postfrontal areas. What is the diagnosis? Of course, we've discussed this, that the reason why Nene self even contributed to this question self. So all of you contributed to it. So basically over here, we are talking about what? Vascular dementia. Vascular dementia. Why? Because of the history of hypertension, stroke, and you know that in stroke, there is what? Inadequate supply of blood to the tissue. So this is what is happening that is making the person have this kind of what? Dementia. And that's what we call it what? Vascular dementia. So your answer is D. We'll talk about this. So if you really want more on the discussion, please check one of the videos. I've forgotten which one it was, either 2015 or something. Clinic of a Research Institute for Occupational Diseases examined a worker who works at a concentration plant and diagnosed him with chronic dust bronchitis. The case is investigated by a commission, including the representative of the plant, the clinic, the local SES. Now, SES simply means what? State Emergency Service. State Emergency Service. Department of Social Insurance Fund, trade unions. According to the regulation on the investigation of whatever. The commission should be headed. Guys, we'll talk about this in our hygiene base, and we said the people that head these sort of commissions is who? Is the local SES. And the local SES simply means what? State Emergency Services of Ukraine. In some books, they write Territorial Sanitation Center. Territorial Sanitation Center. So over here, your answer should be what? Should be SES. C. A 37-year-old woman complains of headaches, nausea, vomiting, and spasms. The onset of the disease occurred the day before due to her overexposure to cold. Overexposure to cold. Objectively, fever is up to 40. Somnolence, rigid neck, Koenig's symptom is positive on both sides. General hyperesthesia, leukocytosis, increased ESR. But you see, because they've mentioned Koenig's, there's no way they'll not check CSF. So cerebrospinal fluid is what? Is turbid, yellow tinted. What changes of the cerebrospinal fluid are most likely? So definitely there's a problem with what? The brain, which is committing of it as what? Meningitis or something like that, isn't it? But the question is, what is the cause of this meningitis? And of course, looking at the cerebrospinal fluid being turbid and yellow tinted is simply a sign of what? Bacterial infection. And so therefore, we are looking at what? Bacterial meningitis. Bacterial meningitis. And of course, in bacterial meningitis, definitely neutrophils are going to be what? High. And so therefore, your answer here will be what? Neutrophilic pleocytosis. So your answer is D. All right. A 48-year-old woman complains of pain in the thoracic spine. Anytime in the thoracic spine, all of you already know the answer. Sensitivity disorder in the lower body, disrupted motor function of the lower limbs, body temperature rise. She has been suffering from this condition for 3 years. Treatment by various specialists was ineffective. X-ray reveals destruction of adjacent surfaces of the 8th and the 9th vertebral bodies. The right paravertebral area of the level of the lesion there is an additional soft tissue shadow. Guys, definitely you are looking at what? At spondylitis, isn't it? So tuberculosis, spondylitis of the thoracic what? Spine. That is what we are looking at for. And usually, they could give you a history of tuberculosis as one of the key things that you also need to look at for to make it as what? Tuberculous spondylitis. Okay. So basically, your answer here is what? Is B. A pregnant woman is 28 years old. Anamnesis, accelerated labor complicated by second degree of cervical rupture. Okay. The following 2 pregnancies resulted in a spontaneous abortion at 12 and 14 weeks. This one, I've done it already. On mirror examination, the uterine cervix is scarred from the previous ruptures at 9 and 3 hours. The cervical canal is gaping. On vaginal examination, the cervix is 2 centimeters. Cervix is 2 centimeters. External orifice is open, 1 centimeter wide. Internal orifice is half open. The uterus is enlarged to 12 weeks. Now, my question is, if you are 12 weeks pregnant, should your cervix be open or not?
No.
Nope. Thank you. So that is your answer. So this is an abnormal thing that happened. In fact, that is the reason why she's been having what? Abortions at 12 and 14 weeks. So if nothing is done about it, this baby is as good as dead, isn't it? So what diagnosis are you going to make? This means that this person is having some cervical insufficiency or inability to hold pregnancy. Inability to hold what? Pregnancy. And so therefore, we call it what? The ischemic cervical insufficiency and habitual non-carrying of pregnancy. Non-carrying of pregnancy. So what do? You have to suture the place so that the place will not be what? Be open. All right. So your answer is what? Here is what? Is E. But there's a term for that. Okay. A 56-year-old patient complains of pain in the epigastrium after eating. Pain in the epigastrium after eating. What comes to your mind? Even before I continue, what comes to your mind? Who can tell me?
Ulcer.
Ulcer, exactly. Thank you. So there's loss of appetite, slight loss of weight, fatigability. The patient smokes, no excessive alcohol consumption, pale mucosa, BP is 110/70, tongue is lacquered, the abdomen is soft, sensitive in the epigastrium area. Blood test 3, hemoglobin color index 1.1. What does color index of 1.1 tell you? Who can tell me?
It's macrocytic.
Macrocytic. What are you looking at?
Hyperchromic.
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 Good. Again,
B12
what deficiency are you looking at?
B12.
B12. So the question now is, where can we now? What helps in the absorption of B12? Who can tell me? Intrinsic factor. Good. And where can we locate intrinsic factors?
In the antrum, the parietal cells of the stomach.
Parietal cells. Thank you.
Parietal cells.
Charlie, you guys are good. Now, on fibrogastroduodenoscopy, they say there's atrophy. What it means is that there is sort of scarring or eating away or erosion of the fundus of the stomach, isn't it? So the question is that what pathogenesis does this disorder have? Of course, this person is having what we call what? And definitely we're having what we call peptic ulcer. You already have told me that already. But what is the causative agent, or what is the reason for this peptic ulcer development? And of course, you are thinking of what? The antibodies that are attacking the parietal cells. And again, this is the reason why the intrinsic factors there is not there. And as a result, absorption of vitamin B12 becomes deficient. And when that happens, your color index becomes high, or you have hyperchromic, you have macrocytic because differentiation is impaired. And of course, the general meaning of erosion of the mucosa means that there's ulcer, isn't it? So definitely that's what we're having over here in this case. So over here, your answer is definitely what? A. It's A. So A should be what? Your answer. But of course, we know that some of the causes of ulcer can be H. pylori, isn't it? But that's not the case in this question. A 26-year-old Secundipara at 40 weeks of gestation arrived at the maternity ward after the beginning of labor activity. Now, the bursting of waters occurred 2 hours prior. That means 2 hours to labor. Discharge. The fetus was in a longitudinal lie with a cephalic presentation, which of course, that is the normal presentation of every good and non-troublesome baby. Abdominal circumference was 100, fundal height 42, contraction occurred every 4 to 5 hours and lasted 25 seconds. Internal obstetric examination revealed cervical effacement, opening by 4 centimeters. Okay, the fetal bladder was absent. Fetal head was pressed against the pelvic inlet. What complication arose in the childbirth? So that means that usually what they're actually looking at for over here is that what term is given to this? Bursting of waters before, before labor. Before labor. And of course, over here we call it what? Early amenorrhea. Early amenorrhea. All right. So basically, that is what it is. And again, we have talked a lot about this premature rupture of membranes and things like that. We've talked about a lot of them. So please do well to watch the Obs and Gynae videos. Okay, do well to watch them because we spend time on it. Really, we spend time on it. Some of you ask questions, difference between early, all the kind of thing. We talk about it. All right. So the answer here is what? Is C. C. Sorry, did I say C? No. Where am I? Hey, who can bring me back? Am I lost? The questions are not The answer is not even there.
It's C, amenorrhea, you're right.
Then the mistake is here.
Yeah.
Sorry. So it's a mistake. So the thing is A, let me spell it for you guys.
Amenorrhea, right?
Yeah. Because I got confused. Yeah. R-E.
There's an N after the ulcer.
Sorry?
Typographical.
So there's an N where?
After the O.
After the O. N.
Hey, which N after which O?
This is not.
The only N is after
A-M-N.
Spell it, I'm not.
Put the L.
So guys, let's continue. So it's a mistake here. Guys, forgive me. It's a mistake. All right. So the answer is C. And I think, of course, you already know the answer. So now this again, hygiene question. You already know it. Bacterial analysis of air in the living space in the winter period by means of Krok apparatus revealed that total number of microorganisms in 1 meter cube of air was 7,200. What is the allowed number of microorganisms for the air to be characterized as pure? And again, I've explained these things. So please write it down again for those who just join us. Now, for clean air, in the winter, it should be less than 4,500. For clean air, or also known as the pure air, in winter, it's supposed to be less than 4,500. In summer, it should be less than 1,500. It should be less than 1,500. Good. That's for clean air. Now, for impure air, it should be more in winter, it should be more than 7,000. For impure air, it should be more than 7,000 in the winter. And then in the summer, it should be more than 2,500. It should be more than 2,500. So over here, the question now is what? What is the allowed number of microorganisms for the air to be characterized as pure? Now, this one means that already it is impure. So that means, come again. So that means up to 4,500. Up to 4,500. Because you say that in clean air, it should be less than 4,500 in winter, then less than 1,500 in summer for clean air. Now, to be considered as unclean, it should be more than 7,000. So already with 7,200, it means it is more than 7,000. That means it's impure. So the answer is B. This is hygiene. So don't ask me to explain the numbers. All right. A 24-year-old patient received a puncture injury below the palpate ligament accompanied by intense arterial bleeding. The best method to temporarily stop the bleeding in the patient would be, again, we discussed this in our previous question. You were talking about tourniquet. So this another way of saying it. So over here, we are going to use what? A compression band. Compression what? Band. That's the definitive treatment for this. Compression what? Band. So the answer here is what? Is A. We've done them, so no confusion. Now, a 42-year-old woman has been hospitalized with complaints of intense pain attacks in the lumbar and the right iliac areas. The lumbar and the right iliac areas, which irradiate to the vulvar lips. Anytime I remember lips, I remember botulinum glands. Okay, now frequent urination, nausea. The pain onset was acute. Objectively, the abdomen is soft, moderately painful in the right subcostal area. Costal vertebral angle tenderness on the right is present. Then urine analysis, gravity is this. Traces of proteins, leukocyte 6 to 8, erythrocyte 12 to 16. And it is fresh. What diagnosis can be seen? The thing that it is what? Fresh. Fresh. That means it's bright red, isn't it? Fresh blood is seen. And the only thing that can happen for us to have this kind of thing is when stone is scratching inside the urinary bladder. Stone is scratching inside the urinary bladder. Because I mentioned that you could have been thinking of what? Pyelonephritis, as your differential and things like that, isn't it? Because of where this is what happening, angle tenderness is present and all of those things. But again, renal colic can also be a cause, or stones in the urinary bladder. So these could be the reasons why we are having these symptoms in this patient. So here, your answer is what? Right-sided renal colic. Right-sided renal colic. This one, I believe we've discussed it severally. A 29-year-old patient works as a motor mechanic. Anamnesis shows frequent exposure to cold. Anytime I remember cold, I remember dummy. Exacerbation of chronic bronchitis attended by the cough with a relatively small amount of mucopurulent sputum. Subfertility or febrile. Anyways, sometimes joined by hemoptysis and pain in the right side of the chest. So vomiting blood, that's hemoptysis. Breathing is vesicular. X-ray shows shadows and a sharp decrease in the size of the lower lobe, distinctly visible on the X-ray image as a streak of 2 to 3 centimeters wide, situated at the angle from the roots to the frontal costal diaphragmatic recess. Guys, we've done this before. What is your likely diagnosis? So again, based on the presenting symptoms, you can think of possibly 3 differentials, okay? Possibly 3 differentials. What are these? We are talking about what? Peripheral lung cancer, tuberculoma, or pneumonia. These things can come to your mind. Tuberculoma, pneumonia, and a cancer. However, with the chest ray revealing these kind of shadows or this globular shade or shadows, if you want to put it, and things like that, you are definitely thinking of what? Of a cancer. And of course, looking at the place where it is happening, that is the roots, or the lung root, makes cancer more appropriate in this question. And that's what over here, we would definitely go in what? With a peripheral lung cancer. And I think this is subfebrile, not subfertility. This is subfebrile. That means low temperature. Subfebrile. All right. So the answer is A. A 26-year-old patient has been hospitalized with complaints of pain in the thorax on the right during breathing. Pain in the thorax, okay, on the right during breathing. Dyspnea, dry cough. 10 days ago, he slipped and fell, hitting his right side, hitting his right side. On examination, the patient lies on the left side. Okay, that means because of the pain on the right, the person cannot actually lie there, but prefer to lie on the left. The right side of the thorax lags during breathing. On the right, there are crepitation and pain in the 3rd and 4th ribs. There's dullness of percussion sound and sharply decreased breath sound. X-ray shows signs of exudate. There's fracture. Now, if you can remember, we talked about this when we're not arguing, but when we're discussing these thoracotomy, and those kind of things. So you see, your question is here. So over here, you would demand what? A surgical procedure. Why? Because of fractures are now involved. So pneumothorax coming with all these fractures and things like that, Charlie, you have to take care of the lungs very well. So you have to open up and attend to the patient. So even said the prosynthesis blood is detected. So choose further tactics. Open up. In fact, there's way to do that in the first place. So your answer yes, what? Is D. Is D. Transfer to a thoracic surgery department. We discussed this the last time we met. So this shouldn't confuse us. A 29-year-old female patient complains of dyspnea, heaviness, chest pain on the right, body temperature rise, disease associated with a chest trauma received 4 days ago. Skin is pale and moist, pulse 90, regular, palpation revealed a dull sound On the right, auscultation reveals significantly weakened vesicular breathing. In the blood, 2.8 color index, hemoglobin, WBC, ESR. What results of diagnostic puncture of the pleural cavity can be expected? Pleural cavity can be expected. Guys, there's a history of trauma. There's a history of trauma. So what do you think you're going to expect when you draw or when you do a puncture? Who can tell me? What are you going to see? Oh, nobody?
Hemorrhage.
Come again?
Hemorrhage.
Yes, hemorrhage. Hemorrhage. You see blood. Hemorrhage. Hemorrhage. Because of the history of what? The chest trauma. The person could be bleeding. The person could bleed. Could bleed. All right, so you're looking at what? A hemorrhagic punctate. Hemorrhagic punctate. Why? Due to the trauma. There could be internal bleeding. Internal, not eternal. Internal. All right. Caries morbidity rate is 89% among residents of a community. It is determined that fluorine content in the water is 0.1. What preventive measures should be taken? So that means with fluorine content to be less than 1, and you're having a problem with the teeth. What does it mean? What it means is that you have to increase the fluorine, because fluorine helps to prevent these kind of problems, isn't it? Or dental caries or tooth decay. Fluorine helps. That is why even when you are brushing, your brush contains, your paste contains some level of what? Some fluorines in there. So now these people have been drinking water with this number of what? Chlorine content. That means it is too low. So to prevent this caries morbidity or tooth decay disease, we have to do what? Water fluorination. So your answer here should be what? Water fluorination. Water fluorination. All right. Examination of a group of persons living in the same territory revealed the following common symptoms. Dark yellow pigmentation of the tooth enamel. Anytime I hear of these things, again, it's like the previous question, isn't it? Put in a different way. There's diffuse osteoporosis of the bone apparatus, ossification of the ligament and joint, functional disorders of the central nervous system. This condition may be caused by excessive concentration of the following microelement in food or drinking water. And again, what comes to your mind should be what? Fluorine. Fluorine comes to mind. Fluorine comes to mind. Too much of it, actually. So we're looking at what? No, this is A, not E. This is A. All right, it's a mistake. This is A, fluorine. All right. In a preschool, when we say preschool, that means children, maybe between the ages of 3 to 5 years, technically, maybe. In a preschool educational establishment, the menu consists of the following dishes: milk porridge from buckwheat. I used to ask myself, what is this buckwheat? Because anytime I have my rice cooker, they always write buckwheat, but I've never eaten this buckwheat, whatever they call it.
Do you remember Rechka?
Yeah, I know Rechka. That is it.
No,
Hey.
Rechka is not buckwheat, though. Hey.
It's buckwheat.
It's another type. It's not buckwheat.
Okay,
It's buckwheat.
just before we argue, thank you. Just before we argue, thank you. Thank you. I know you people. I don't trust you guys. Pasta with mixed meat.
I have it in my fridge. That's what I'm telling you.
Cucumber salad, kissel, thin berry jelly, rye bread. I don't even know what these are. What dish should be excluded from the menu? So basically, they are telling us that there's a problem with one of the menu that we have to take out for people who are between the ages of 3 to 5 years. So what are we going to look at? So generally, children and adolescents should eat sufficient nutritious food and drinks to grow and become normal or develop very, very well. And by saying that, they need to limit the intake of food that are high in saturated fat. So food that are high in saturated fat should be exempted. And this food could include what? Many biscuits, cakes, pastries, pies, processed meats, commercial burgers, pizzas, fried foods, potato chips, crisps. Name them. Name them. There are a lot of them. Now, if you look at the option that we're having here, of course, the one that we can easily exclude would be what? Would be the meat part. So when pasta with what? Minced meat should be excluded. Should be excluded. The rest, we can take them. So yeah, no, the answer is A. This my secretary is getting paid for nothing. Oh, the answer is A.
You can employ me.
I can employ you. I've heard you. Yeah. The answer is what? The answer is A. The answer is A. An infant has been born at 41 weeks, 41st week of gestation. Sorry. The pregnancy was complicated with severe gestosis of the second semester. Weight of the baby is 2,400. What is the normal weight of a baby? Who can tell? What's the range? Oh.
2,800 to 3,500.
2,000 what?
2,008 to 3,500. But no,
2,600 to
3,900.
to 3. Actually, it's 3,500.
But 3,500 is optimal, Dr. Baha.
It's, well, that I'm saying. So, well,
because like the differentiated, there's like normal birth weight and there's low birth weight, very low birth weight.
Yeah.
Exactly. Good.
So it's like 3,500 is like the optimal.
Optimal. Thank you. So in the height, 50. Skin is flappy. Now I asked this thing because of the answers. Don't worry, you get there. The layer of subcutaneous fat is thin. Hypomyotonia. Neonatal reflexes are weak. Internal organs are without pathological changes. The newborn can be estimated as... Now, you don't need to know whatever is happening here. Just look at the history of the baby, and this is where your answer comes from. So first of all, this baby is a 10 baby. True or false? Yes. So this was a full-term infant, but with 2.4, definitely is less than the norm that we know. The normal or the optimal growth rate that people are saying. The optimal growth rate that we know. So this is what? Below normal. So definitely we're having what we call what? A full-term infant with a prenatal growth retardation. Growth retardation. So over here, we are looking at what? At E as our answer. Internal organs, reflexes are weak, everything. All right. A patient is suffering from infiltrative pulmonary tuberculosis and was prescribed streptomycin, rifampicin, isoniazid, parazinamide, vitamin C. Okay. RIPE is the treatment for tuberculosis. RIPE. So in case in absence they ask you for treatment for tuberculosis, don't say you don't know. It's RIPE. All right. And this refers to the initials of what is being given over here. So the question now is that's not the problem. The question now is that 1 month after the beginning of the treatment, the patient started complaining of reduced hearing and tinnitus. What drug was the side effect? What drug was the side effect? So basically, that is the question. And usually, we know that people who take aminoglycans, aminoglycosides have problem with what? Hearing, isn't it? And of course, talking about aminoglycosides, I'm specifically telling you that we are talking about what? Streptomycin. Because streptomycin is an aminoglycoside or glycosidic drug. So it can even lead to renal toxicity and cardiac toxicity and stuff like that. So please take note. Hearing loss and things, it can happen like that. All right. So the answer here is what? Is C, streptomycin. Now in isoniazid, you're thinking of more of neuritis. Okay, think of more of neuritis. All right. A woman has developed sudden thoracic pain on the right with expectoration of pink sputum. pectoration of pink sputum, and a body temperature rise to 37.7. On the 4th day after the surgery, a cystoma of the right was there. Sorry, they said what? Temperature rise to 37 degrees on the 4th day after the surgery for good. So now the person was having a cystoma of the right ovary, and they did what? Surgery. And after the surgery, all of these things are happening. That's basically what it is. Now, on lung examination, dullness of the lung sound on the right is observed. Isolated moist crackles can be auscultated in the same area. What complication is the likely what? Diagnosis. What complication is the likely diagnosis? So again, looking at this, so now definitely there's a complication after the surgery. That's what they brought it there. Complication after the surgery. And who can tell me one of the complications after every surgery? Give me 2 complications that you can think of after every surgery. 2. Oh, anyone?
Bleeding.
Pulmonary embolism.
No. Okay.
Sepsis.
Exactly. So infections and bleeding. These are very, very common complications when it comes to, when it comes to surgeries. So always put it at the back of your mind. Okay. Now, come back to your question. Now, they say the person is having what? Develop a sudden thoracic pain on the right with that means bringing out what? Sputum, a pink sputum, and a body temperature rise, isn't it? So over here, you might be one way or the other tempted to say, well, we can think of what? Infection as the answer, isn't it? You could be tempted, but no, over here, we are going to be looking at what? At infarction. Bleeding can also ensue. And with bleeding, it means that enough blood might not be entering into the what? The heart. Into the lungs as well. Don't forget that. It can happen. Okay, so infarction can ensue. So-called pulmonary what? Infarction. Pulmonary what? Infarction. So that can ensue in this patient for which we are having this sudden chest pain and things like that we are having in this question. So over here, we are looking at what? More of what? Infarction, because we are thinking of a complication that could involve what? Bleeding. That could involve what? Bleeding or reduced blood flow to the lung tissue. And again, somebody mentioned embolism. Yes. So when you do surgery too, an embolus can also move and go and lodge into the lungs, isn't it? Yes. An embolus can move and lodge because you're doing surgery. So all of these things are bound to what? To happen. So either the hemorrhage could be one disposing factor or embolism can move there to go and lodge and block the flow to the lungs. And so therefore your answer is C. All right. A 58-year-old patient was delivered to an admission room with complaints of pain in the thorax on the left. On clinical examination, aside from tachycardia, no other changes are present. On ECG, there's what? Pathologic wave of kill in eye, blah, 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 lead, and a doomed ST elevation with negative T. Now, anytime you start thinking of ST elevation, ST depression, what comes to mind? Myocardial infarction, MI, comes to your mind. So either we are having a depression or we are having what? An elevation. This is classic for myocardial infarction. Now, what is the difference between left and then the right? What is the difference between anterior and posterior? That is why you now need to know. But of course, generally we know that myocardial infarction normally affects the left ventricle because that's where pumping of blood takes place a lot. That's where the muscles contract a lot to push blood for systemic circulation. So even without knowing this, know that the left ventricle is what is affected or is being affected. Okay. And like I said, if you think of elevation and depression of ST segment, you are thinking of what? An MI. So now, what can help us to differentiate between an anterior MI and a posterior MI? That should be your headache now. But until now, you should know that your diagnosis is definitely what? Myocardial what? Infarction. Now, when we are having ST elevation, then we are thinking of what? Anterior. ST elevation, we think of what? Anterior segment. Also, we think of what? Anterior ventricle. Yep. And when we talk about, a depression or ST depression, we are dealing with the posterior area. So over here, with a doomed ST elevation, definitely we are going to consider the anterior area. So over here, your answer is B. Yes. Quick.
Dr. Baha,
yes.
With ST elevation,
yes,
it's not only anterior, or
no, that's
because
what I'm
like
saying.
What I know is that like to determine which part of the heart is affected, whether anterior or posterior. Now, usually with anterior, it affects the you see the pathological Q wave. Yeah. You understand me? Yeah. In the first standard lead, as well as AVL. Do you get me?
Yeah.
But then in posterior, you see it in the third standard lead as well as AVF.
Good.
Do you get it?
So you see, these are more of ECG findings, and sometimes many of us will get confused with this first surgery because we have about 9 leads. I hope you guys know that, and every single one of them we have to understand them. Okay, so sometimes to reduce complication of understanding things, I have to, in a way, make it simplify for you guys. But yes, exactly what you said. Perfectly right. Or perfectly so. But then, like I'm saying again, usually, when we have, we have non-STEMI and STEMI.
Non-STEMI, yeah.
Good. Like, I don't want to just enter into plenty things. You understand? But we are STEMI, non-STEMI, all kind of things. They are all form of what? Myocardial infarction. Okay.
Yeah.
But to just simplify things, mostly, like I said, mostly, when we have the elevation, okay, when we have the elevation, the anterior is mostly affected. And when we have the depression, the posterior is normally what? Affected. This is just to, summarize everything. But like I said, I want to take my time to go through some of these things with you guys, including these systolics and stuff like that, which Christopher will have to remind me of it anyways. All right. So basically, that will be it for this particular one. So over here, we are looking at what? Acute ventricular anterior myocardial infarction as our answer. And of course, the left ventricle we're looking about. So here, we are going with what? With B. All right. So great for that input. All right. So we have a 48-year-old woman with thermal bends of both hands. Thermal bend. The epidermis of the palms and the backs of her hands are exfoliating. That means they are peeling, isn't it? Exfoliating. And blisters filled with serous liquid are forming. The forearms are intact. What diagnosis is the most likely? So definitely they want to know what degree of burn it is. What degree of burn it is. So basically, let's go through the degree of burn and you can be able to know what your answer really is. So with the first degree burn, it affects only the outer layer of the skin. It can cause pain, redness, and swelling, but it affects the outer layer of the skin. With the second degree burn, it affects both the outer and the underlying layer of the skin. Just the underlying layer of the skin. And again, it can cause pain, redness, swelling, and blisters formation. So if you look at over here, we can have this thing happening. We can have blisters formation happening in this question, isn't it? So again, but this one has gone beyond just the superficial layer, isn't it? So that means we have entered into what? The second degree of burn. But let me continue. Now we can talk about what we call third degree burn. So third degree burn affect the deep layers of the skin. Deep layers of the skin. Deep layer. That means it's going to what? The dermis. The dermis, the deep layers of what? Of the skin. So that's what the third degree is all about. Then we now have what? The fourth degree. But before that, even the third degree, we can have what we call full thickness burn. We can have white, blackened, or burnt skin. And the skin can even be numb. Good. Now we also have what we call the fourth degree. Fourth degree burns. So fourth degree burn goes through both layers of the skin and underlying tissues, as well as deeper tissues, possibly involving the muscles and then the bones. The bones are all coming in play. And of course, over here, bones are not coming into play. Muscles are not being affected. So obviously, fourth degree burn is taken out. And again, first degree burn is taken out because it's not only affecting what the superficial layer, but it also goes a little bit deeper. So over here, we can consider what we call the second to the third degree burn. Second to the third degree burn. So over here, D will be most appropriate. More appropriate. All right. A 39-year-old patient complains of morning headache. The appetite loss. Some people are posting on the Telegram page. If possible, put the same information on the, how do you call it? On the text area, because some people are still not on the Telegram page. Me, my friend is Kalila. So Kalila, I'll fight for you all the time. Okay? I'll fight for you.
So I can rest assured and sit back.
I'll fight for you all the time. All right. So we're having, what? You are jealous. Go away. Appetite loss, nausea, morning vomiting, periodic nasal hemorrhages are present. The patient had a case of acute glomerulonephritis at age 15. Now he's 39. Guys, anytime they tell you a disease, start looking out for what? Anytime they tell you a disease, start looking out for what? Who can tell me? 8 what? Complications. Thank you. I see how Christopher has nice voice like that. Why? Please, I'm not a girl. Biko. Now, examination revealed rise of arterial pressure up to 220, 130. Skin hemorrhages on his arms and legs, pallor of the skin and mucous membranes. What biochemical parameter is most important for making diagnosis in this case? So, now the question now is that you have read that the person had acute case of glomerulonephritis 15 years ago. So what do you think can happen in the kidney? Who can tell me? Kidney what?
Failure?
The filtration.
Kidney failure. Yes. Yeah. Kidney failure could ensue. And if kidney failure has ensued, what happens is that there will be low filtration rate, isn't it? Or filtration will be impaired. And what is the golden tool for checking the functionality of a kidney? Let me put it that way. The golden test is what?
Creatinine.
Thank you. Creatinine. That is the golden tool. Or the golden marker for kidney functionality. That's normally they say do BUE creatinine. The creatinine is very important. So over here, you are looking at what? The creatinine. All right.